Good afternoon.
Good afternoon, Madam Chair.
And for the second time today, we are meeting for a briefing. This briefing will be on certified community behavioral health clinics. We'll hear again from the Maryland Department of Health with Perry Briskin and Alyssa Lord. We're going to hear from Sheppard Pratt, and we're going to hear from the Community Behavioral Health Association of Maryland. I want to welcome our senators that have joined us from Budget and Tax, Senator Zucker, Senator Jennings, Senator Augustine, and Senator McRae, who I almost forgot. So thank you for joining us, and I hope you find the presentation helpful. So we will have Perry and Alyssa come to the table, please. There's a lot of interest in this issue because the room certainly filled up. Thank you.
Good afternoon. Who knew that CCBHCs would be such a hot topic today? Glad to be here with you all. Good to see you. Alyssa Lord, Deputy Secretary of the Behavioral Health Administration, joined by Deputy Secretary Perry Briskin, of Deputy Secretary of Healthcare Financing and State Medicaid Director. So I am pleased to provide an update today on Maryland's status of the planning grant that we were awarded by SAMHSA in December of 2024. You will also hear from some of our colleagues from CBH and Sheppard Pratt who are actively partnering with us on the planning grant activities. So for some history and context, more than a decade ago, Congress passed through the Protecting Access to Medicare Act, CCBHCs, or Certified Community Behavioral Health Clinics. And this legislation was designed to have a coordinated set of behavioral health services either under one umbrella or through a partnership through a constellation of organizations, or known as designated collaborating organizations. And for states to become CCBHC providers, they must go through a planning grant process, which is what we are currently undertaking, as well as apply for a demonstration grant. And as part of that, what you see here are some of the core requirements. So states must require certification standards, and I'll talk a little bit more about that later. We must establish a prospective payment system. So you'll hear the term PPS a fair amount, and that's what that alphabet soup stands for. That is not dissimilar from what you might see from an FQHC rate, where it is a bundled rate, so they get paid one rate for that core set of services. And then we must submit an application to SAMHSA to become a demonstration state. And with that, this is, bless you, this is the set of 9 core services that a CCBHC must execute. And it includes crisis services, community-based mental health services, targeted case management, psychiatric rehabilitation services. The one thing I will say is these are many, many services that the state of Maryland already provides through the public behavioral health system or through existing funding mechanisms. So this isn't necessarily new services. This is the bundling of services under the CCBHC model. And so from a national perspective, there are currently 199 fully certified CCBHCs in 12 states that are reimbursed through that PPS. And what you will hear also is that there's more than 500 CCBHCs or lookalike CCBHCs nationally, but it is only the certified entities, the certified CCBHCs, that are eligible to be paid through the PPS. So that is that key distinction. And so there have been additional states that have been awarded, for a total of 20 states that are in the process or have implemented CCBHCs. And what you see here is the 10 most recent states that were added in June of 2024. One of the key considerations that we've been taking a look at here in the state of Maryland is what is the information that we are able to glean from other states as it pertains to cost, quality, and outcomes, right? Our goal here is to protect services for Marylanders, but also make sure that they are accessing high quality services. And so we have been taking an extensive look, and almost every year, HHS, they have a division there for planning and evaluation, releases a report taking a look at how states have performed in CCBHCs. And so this is just some of the most recent, sharing a couple of stats. So they take a look at hospitalization rates, emergency department rates, ambulatory service use, as well as accessing specific services for substance use disorders such as Medicaid-assisted treatment or other types of SUD services. And so what they found in the most recent ASPE report was an increase in 2 states in total Medicaid spending for CCBHC participants. 1 state saw an increase in access to ambulatory care, including medication-assisted treatment for SUD. And then some states, and this is again looking at Nevada, Minnesota, and Oklahoma, saw a decrease in psychiatric hospital and emergency department utilization, but Oklahoma only saw it for adults and people with SUD. So in terms of the Maryland landscape, I think many of us here are very familiar with the legislation that was passed in 2023 that required the state of Maryland to apply for the planning grant and subsequent demonstration grant. We, as I said before, we were awarded the planning grant in December of 2024, and that contract covers partnering with the Mental Health Association of Maryland, who is working with us and the existing CCBHCs on consumer engagement, stakeholder engagement, mapping of services, the community needs assessment, and I'll talk a little bit more about the ongoing planning activities in just a moment. Myers and Stauffer, who is an independent third-party entity who is working with us on cost reporting and provider training, as the PPS rate is built off of cost reporting. So providers have the opportunity to state what their expenses are. And then we have used it to support some internal staffing and some modifications for our ASO. And then I will say there was a delay in starting the planning grant activities, as during last legislative session, there was BRFA language that was introduced that was subsequently retracted that would not have advanced this work. But that being said, we have advanced this work, and we are meeting regularly, monthly, if not more than monthly, with our key stakeholders. And then we have 5 CCBHC expansion grantees, and what does that actually mean? So these grantees receive funding from SAMHSA directly to support their alignment and coming into compliance with becoming a certified CCBHC. You'll hear from our partners. I know Sheppard Pratt is here and CBH, who represents many of our CCBHCs. Now, I do want to add a friendly amendment to the slide. I had a chance to connect with our CBH colleagues prior to this meeting, where it says at the end of our slide here that none of the grantees currently provide all 9 core services. We have some outdated information, and I have been told by CBH that our existing CCBHC grantees, either themselves or through partnerships, are providing all 9 core services that would make them eligible to apply as part of these certification standards. And where are we from a timeline perspective? So this just gives you sort of the broad swath of our current standing. And so we've started the cost reporting training. And the one thing I do want to highlight here is we do have a joint chairman's report that is due to the General Assembly May 1st of 2026, which was for the department to outline some of the questions that came up during last legislative session regarding cost, quality, and outcomes. And so that is currently in the pipeline, and we will have it submitted by the due date. The one thing I also want to flag here is that the department, given that the department started the stakeholder work later, that we had applied to SAMHSA for a no-cost extension, and that extension was granted just this past December 24th to be exact. And so what that does, it allows the department additional time to work through extensive planning grant activities that would make a future application in the demonstration grant hopefully more successful, but it allows us really to complete the requirements, because otherwise we would not be eligible for that demonstration grant without completing all the planning grant activities. So what you see here is affording us the additional time to complete those activities and then looking at a future outward year, because SAMHSA does not release demonstration grant applications every year. It is typically on an every 2-year cycle. And this provides an overview of the various different activities that are currently in flight, including getting input from our consumers that are receiving services through our existing expansion grantees, creating the certification standards, which includes staffing, and there is a whole subset of requirements that are included as part of the certification criteria. And then we also have to finalize that application for approval. We need to be able to identify 2 CCBHCs. One must be a rural CCBHC, and one can be from another part of the state. And then we need to establish that PPS that I mentioned before. And so what the department has put forth is this recommendation that would allow us more time to make sure that we are completing these planning grant activities. We also are unfortunately staring down potentially another government shutdown. And so we are trying to take that into account. And the other caveat here is when Maryland was awarded our planning grant, we were one of 15 states that were awarded, and SAMHSA is only intending on awarding 10 demonstration grants. That being said, SAMHSA has not yet released the application for demonstration grants. It is posted as is forecasted on the SAMHSA grants dashboard, but it has not yet been released to date. And so again, these are just some of the considerations that we took into account with making this recommendation, is making sure that we are completing those activities. The other thing I do want to underscore is that if we were to wait until a future year, individuals that are actively receiving services now, there would be no disruption in care. And you'll hear from our Sheppard Pratt partners that, as I said before, many of these services are already existing. So for those that are receiving services on outpatient mental health, they would continue to receive those services and get reimbursed through the public behavioral health system. So those mechanisms are in place, so there would be no disruption in care. And then I know there is a concern about the expansion grantee funding sunsetting. It's our understanding that there are 3 expansion grantees whose funding sunsets in end of September of 2026, and 2 that sunset at the end of September of 2027. I personally spoke with SAMHSA, who assured that all 5 Maryland expansion grantees would be eligible for additional future expansion grantee funding. The other thing is, in talking with our CBH and our Sheppard Pratt partners, we are aware of a request for bridge funding should federal funding not be awarded, and those are things that we are actively working through from a financial modeling perspective, which is also challenging during a particularly lean fiscal climate, but engaging in those ongoing conversations. And then this just gives you a sense as to our cost projections of what we anticipate would to cost to implement 2 CCBHCs. It's looking at about $13 million in total funds. It does allow for us to draw down a 65% FMAP from Medicaid, but again, it would look like anywhere from $13 to $15 million would be needed to support 2 CCBHCs. In terms of next steps, we are actively working on that JCR, which you see here outlays what the terms are of the information that we will be providing. And then I would be remiss if I didn't mention that we're slightly behind the times, but there was the HOPE Act, and I'm sure many of you remember the HOPE Act of 2017, but the department is undertaking an extensive behavioral health rate setting study over the next 12 to 18 months, and we think this information is incredibly important as we think about load balancing our current rate structure, especially if we are going to be moving towards adopting CCBHCs. And with that, the last thing I will end with is that we are continuing to lean in learning from other states and taking a look at their evaluations as it pertains to cost, quality, and outcomes, and much of that will also be included in the JCR.
Listen, now, Perry, are you there just for support?
I'm here for support.
Okay, thank you. Senator McCray has a question.
Thank you, Madam Chair. And thank you both to the Madam Deputy Secretaries. You spoke about the BRFA last year and the recommendations that was put forward. and obviously the legislature had a different position on it. But if you can elaborate, I believe there's language in this BRFA. Can you just speak to what that is?
Yeah, so it is our understanding in the language that we saw last week when the BRFA language was released is that there is a $4.6 million dedicated purpose account for future CCBHC use.
I guess I'm speaking towards just the delay language that was inside of the BRFA.
Oh, so the change there is from the department shall apply for the demonstration grant to a may.
Can you just help me understand the reasoning?
I think some of this is, what I would say is twofold. One is the uncertain federal landscape and what's happening, right? We have no way of predicting what the feds are going to do. I think many of you are aware we had a surprise moment not too long ago where we received a funding rescission overnight and then it was withdrawn 48 hours later. But this is unfortunately the environment that we are in. And then I think it's, again, trying to understand, the effectiveness and cost of CCBHCs and what is the model that we would look to implement here in Maryland.
Couple points, Madam Deputy Secretary. So I heard you during the presentation talk about the communication with the stakeholders. Before I get to my point, can you just speak to what level of communication went to stakeholders about the BRFA action that you're putting forward?
For this most recent BRFA?
Yes, ma'am.
There was not communication because we received the language when the BRFA was announced.
Yeah. I think that some of the challenges is that with last year's actions, some of the stakeholders feel as though there was some delay in taking action. I think that the legislature spoke in reference to like what position we would like to take. But I know that more recently, I've been locked in on DDA stuff, so I haven't been with the CCBHCs, and I just believe that communication is so important in how we communicate to our stakeholders, especially in a thoughtful way, as we move as an executive branch, but also the legislative branch is very, very important. And so keep me posted when that conversation does happen.
Sure.
But more importantly, just in reference to their concerns about like the intentional level of delay is also important. I'll leave it there, Madam Chair, because I wanted. Yes, ma'am.
Thank you, Senator, for your feedback.
Do I have any more questions on this presentation? Senator Washington.
Thank you, Madam Chair, and thank you for this presentation. Can you just tell me the difference? Difference between the CCBH clinics and the adolescent psychiatric beds or systems?
So for CCBHCs, those are all outpatient services.
Okay.
And for adolescent psychiatric beds, those are inpatient services.
Got it. Okay. All right. That's it. Thanks.
Well, you did really well. There's no other questions. So thank you very much. And next, we have Sheppard Pratt coming to the table. I don't have any names. Was I supposed to have names? This is Marshall Henson, Vice President and COO of Community Services.
Yes.
Right? Marshall, who do you have with you?
I'm CBH. We're just
Okay.
going to tag team off each other if that's okay.
Okay, well, we're going to do Sheppard Pratt first.
No worries at
Okay?
all.
All right, thank you.
Okay, great.
Good afternoon.
The slides are out.
They should
Do
be.
we have Sheppard? Oh, gotcha.
There we go.
My bad.
Good afternoon, Chair Beidle, Vice Chair Hayes, and members of the Senate Finance and Budget and Tax Committee. My name is Marshall Henson. I'm the Vice President and Chief Operating Officer for Sheppard Pratt for our community services programs. I want to be able to talk to you a little bit from a provider perspective of the importance of CCBHCs and what our motivation is for going down this path. So to give you a little bit of an overview, we serve 80,000 Marylanders each and every year. We're in each and every district across the state of Maryland. And we're in 400 sites across 16 different jurisdictions. So we run a full continuum of care, behavioral health care. We run school-based mental health services, psychiatric hospital care, and care coordination for high acuity and high utilizer populations. This is just a little look of all of our locations, all our programs and services across the state. And now I want to talk to you about our core motivations for why we went into CCBHCs. So we have established our CCBHCs on top of our outpatient mental health clinics, and that is the typical trajectory for CCBHCs. So it's important that we spend just a second talking about outpatient mental health clinics. So the current outpatient mental health clinic rate structure is fundamentally misaligned with high acuity care. So those high utilizers that come through the behavioral health system. Maryland's OMHC fee-for-service rates have not been updated in any meaningful way in over a decade. The current rate methodology reimburses short, episodic encounters rather than the intensive, team-based model that's required of individuals with serious and persistent mental illness and co-occurring substance use disorders. CCBHCs were designed to fix this exact problem. The model is built around a prospective payment system, and that funds the entire care team needed for high acuity populations. Maryland's demonstration grant allows us to build that model, but without the rate system, we're forced to operate a federally designated clinic on a state outpatient rate, which is not financially possible. So Maryland's current approach is a half build at this point. Under the demonstration grant and without that rate structure, we're not able to hire the number of care coordinators and other specialized disciplines needed to carry out the full mandate of CCBHCs and to achieve all those goals that each of us want in every jurisdiction across the state. So what are some of those things? Emergency department diversion, post-crisis follow-up, and chronic disease management, right? Those are the things that we all share in common. Fee-for-service inherently undervalues what makes CCBHCs effective, right? So outpatient mental health care rate methodology only pays for those billable encounters, not the work that happens between those encounters. So think about what that work is: managing medications for individuals with severe and persistent mental illness, coordinating with hospitals and emergency departments, helping patients obtain benefits, addressing transportation, insurance lapses, and other social determinants of health barriers. We also help prevent crises before they escalate. With that care coordination, making sure that people get the care in outpatient settings without having to seek it in a higher cost, higher acuity setting. So thinking about what CCBHCs look like in practice. So a couple of the differences between CCBHCs and OMHCs from a client perspective. This model, CCBHCs, is really built for people with severe and persistent mental illness and changing that trajectory of cost over time. Care coordination is that differentiator. Again, it's all that work that happens between those encounters. We also work on that misconception that clients have of needing to access care first through emergency departments and higher levels of care. So we are often able to redirect clients to primary care physicians or coach them through simple nursing methods to make sure that they stay safe and well in the community without having to clog up our emergency departments as well as our inpatient psychiatric system. So I want to move a little bit to who we serve. You can see there at the top, we serve over 2,400 people across our 2 CCBHCs today. Primary diagnoses are mood disorders, schizophrenia, and anxiety disorders. And we have co-occurring substance use disorders that we treat with regularity as well. You can see we are heavily saturated with a Medicaid population, sitting at about 78% of the individuals that we serve. We serve all the age groups, right, 0 to 17, all the way up to geriatric services. And we have a number of referral sources. It runs the gamut, but largely acute care hospitals, other caregivers, family members, and other clients that utilize our services. We also plug into the 988 system to make sure that those clients that aren't connected to behavioral health have a front door to the CCBHCs. So when I look at the most frequent services that are delivered, you can see a list of all the services that we provide in the CCBHC, but I want to draw your attention to those top 5 services. So it really is part of that core pillar of the services of CCBHC. So it's that psych rehab service, it's the medication management, individual therapy, and nursing care coordination. So let's talk about what's working and setting a new standard. So when we look at our outcomes related to CCBHC, these are the things that matter to all of us. So I want to draw your attention to the middle of the slide to those outcomes. So what we have seen in our population after starting to receive CCBHC services is a 45% reduction in emergency department visits for that client population across the state. And reduced reliance on inpatient psychiatric beds. What we also see is improvement in physical health, right? Those things that also tend to be costly within our healthcare system. So we've seen over 55% of our clients with hypertension have reduced their blood pressure to healthy levels. And we've also seen 59% of clients with diabetes reduce their A1Cs. Again, further improving the impact on hospital settings. I want to give you just a quick look at a client case. This is a very typical client case that comes through our front door. 38-year-old female diagnosed with schizoaffective disorder, bipolar I disorder, and diabetes. The reason that she came to us was for that uncontrolled diabetes, blurry vision, and cataracts. She had multiple emergency departments visits over the course of the year. She also had no psychiatric provider established. And she was scheduled for cataract surgery, but was not able to have that surgery because of uncontrolled diabetes. So what interventions did she get from CCBHC, from Sheppard Pratt? She got that psychiatric assessment and connection to a psychiatric provider. She received that referral and care coordination between her physical health team, as also with her behavioral health team, ongoing education and medication compliance, and we established an affordable prescription plan for her. At the end of the day, what that resulted in is she was medically cleared to have that necessary surgery. There were no further ED visits or inpatient psychiatric visits. She established a primary care physician, a psychiatric provider, pharmacy services, and an endocrinologist for ongoing care and treatment. And we're happy to report that this client is actively engaged in employment. So those are the types of outcomes that we see come through CCBHC every day. This is not a dramatic case. This is simply the type of client that we see each and every day. So, simply put, this has reduced reliance on emergency departments for behavioral health needs. It's also improved the physical and mental health outcomes, and we have expanded same-day access for those clients. We've implemented federal quality standards at the state level in Maryland, so really raising the bar for clinic services, and we've served as a proof of concept for the state. There's a few operational constraints that we have. Lack of Medicaid reimbursement system. So without that reimbursement system, it makes it difficult for us to build a budget, hire the staff that we need, and we know that grant funds are time limited. So when we hire those staff, it's under the commitment of that 1-year period, right? Which also impacts our ability to scale. So we know the number that we're serving. We know that we have a lot more people that want to receive that services and needs to receive those services in order to keep people out of emergency departments and higher levels of care. So the reality is operating a federally defined model without federal payment and drawing down those federal funds is unsustainable for our future in Maryland. So our grant ends September 29th, which really leaves CCBHC's operational future uncertain. So we have an opportunity here to really make a choice in how we view our progress for CCBHCs and how we chart the path for the future of CCBHCs in Maryland. The question is not whether CCBHCs work. That has been established, and we've seen other states do it. The real question is whether Maryland will be able to take full advantage of this opportunity to invest in a sustainable system for outpatient care. So I thank you for your time, and I'm happy to take any questions.
Thank you for your presentation. I'm looking to see Senator Ellis.
Yeah, thank you, Madam Chair. Thank you so much for your presentation, sir. Appreciate it. In your slide about who we serve in clinical focus areas, I noticed you don't have like veterans listed. So do you have any services to veterans, especially under their fee-based program? I know especially those veterans who might not be close to a VA hospital. Since you're all over the state, that's why you see you smiling. So.
Absolutely.
Okay.
Absolutely. Veterans come through every part of our continuum of care, whether it's inpatient psychiatric care or all of our outpatient service offerings. I didn't include them on this slide here, but we serve veterans across the full continuum of care.
Okay, thank you for that. Thank you.
Do I have any other questions for Sheppard Pratt? Thank you very much for your presentation and the work that you're doing. Thank you.
Thank you.
So next we have Nicole Granner, Community Behavioral Health Association of Maryland.
Absolutely. Good afternoon, Chair Beidle, members of the Finance Committee, and members of the Health and Human Services Subcommittees. For the record, my name is Nicole Granner, and I am the Director of Government Affairs and Public Policy with the Community Behavioral Health Association of Maryland. And I appreciate the opportunity to be here with you today. But before I get into my slides, I want to be clear about why I'm here. The General Assembly has supported CCBHCs for years because they are designed to address the very problems that you keep running into. Hospital overstays, access gaps, emergency departments being used as the default front door for behavioral health services, and kids and adults cycling through crisis and inpatient settings when community care isn't available fast enough. You've continued to support the CCBHC model through legislation and budget decisions because it directly addresses those challenges. So today's conversation is about whether Maryland protects the progress it has already made or risks sliding backwards at a moment when the need for community-based care has never been greater. CBH is the statewide trade association representing Maryland's community-based behavioral health providers. Our 95 members deliver mental health and substance use services across the full continuum of care, serving children, families, adults, and seniors in urban, suburban, and rural communities across the state. And importantly for today's discussion, CBH represents all 5 of the Maryland's current Certified Community Behavioral Health Center expansion grantees. These providers have been operating under the CCBHC model for nearly a decade, with the first CCBHC expansion grants beginning in 2018. They are not pilots on paper. They are functioning clinics in Maryland right now, delivering care, meeting federal requirements, and producing measurable outcomes. I'm not here today to convince you that behavioral health needs your attention. You already know that. What I want to do is make sure that we're all talking about the same model and the same decision points. So today I'll start with what the CCBHC model is and how it's designed to address the system challenges you've been grappling with for years. Then I'll talk about the outcomes we're seeing both nationally and right here in Maryland when the model is implemented as intended. I'll walk through what's at risk if Maryland slows down now And I'll close with what's needed to protect the investment that you've already made and keep this model, this work moving forward. Certified community behavioral health clinics are a federally defined clinic model designed to meet comprehensive behavioral health needs for children and adults. And that federal definition matters because it establishes enforceable requirements around access, services, care coordination, and quality and accountability. This slide shows the required activities and service array under the CCBHC model. The intent of the model is simple. People should not have to navigate multiple systems, wait lists, or referrals just to get basic behavioral health care. As CCBHC expansion grantees, Maryland CCBHCs are required to attest to SAMHSA that they offer outpatient care, 24/7 crisis services, care coordination, substance use treatment, and supports for children and adults under one accountable structure, either by providing these services themselves or, as you heard, through a formal agreement with a DCO. CCBHCs function as a reliable front door for behavioral health care. Same-day access reduces emergency department utilization by engaging people earlier before conditions escalate to crisis. And required crisis services prevent unnecessary inpatient admissions and pediatric overstays. Care coordination improves discharge planning and continuity so people don't fall through the cracks after an inpatient hospitalization. And whole person care reduces repeat crises and justice system involvement by stabilizing individuals in their communities. And we have evidence that this works. Nationally, CCBHCs now operate in 46 states, covering nearly 60% of the United States population, with strong bipartisan support at the federal level. When those $2 billion of SAMHSA cuts were implemented, CCBHCs were not impacted by those. Maryland CCBHC expansion grantees serve 6,400 individuals in FY25. This is not a new or experimental model. It is the direction that behavioral health policy is heading. In New York, which has implemented the CCBHC model at scale, the state saw a 61% decrease in clients using hospital inpatient services and a 54% decrease in all hospital readmissions. Those are system-level outcomes tied directly to earlier access, stronger crisis response, and coordinated transitions out of inpatient care. And we see the same patterns here in Maryland. Maryland CCBHC grantees perform significantly higher than the national average on 7-day follow-up after a hospital discharge. And in Montgomery County, Cornerstone CCBHC implementation has resulted in 83% fewer emergency department visits, and their inpatient utilization has gone down 35%. On the Eastern Shore, Healthport CCBHC has expanded assertive community treatment and reduced hospital length of stays by 40%. And in Baltimore and Prince George's counties, Volunteers of America has expanded access to services by offering extended weekend and evening hours. These outcomes are important because they show exactly what is at risk if CCBHC capacity erodes. The CCBHC demonstration is the mechanism that allows Maryland to move from grant-funded participation to a sustainable model. The CCBHC demonstration allows Maryland to operationalize CCBHCs over time. It creates predictable, accountable funding through the prospective payment system, which reimburses providers based on the actual cost of providing the required services. It's the same principle long used for FQHCs and managed care organizations. And importantly, it brings an enhanced federal Medicaid match, which is currently 65%. It allows the state to control timing, scale, and participation. The demonstration does not require immediate statewide expansion. It does not force uniform implementation across all communities, and it does not replace all other funding or eliminate the need for phased growth. Proposed BRFA language would change Maryland's obligation to apply for the demonstration from shall to may, delay the demonstration application from FY26 to FY29, and tie action to future budget availability. This is not a technical adjustment. It materially alters Maryland's trajectory and will have significant consequences. As you heard, 4 of the 5 CCBHC expansion grants expire in September of 2026. Many of the CCBHC grantees have used their grant funding to supplement Medicaid services or implement services that are not Medicaid reimbursable, including on-demand medical translation in over 200 languages, nursing staff within residential programs and outpatient mental health clinics, benefits counseling, and expanded care coordination and peer support services. Without a clear path forward, access gains are at risk of rollback, crisis capacity weakens, workforce investments become unsustainable, and the pressure shifts back to emergency departments and inpatient units. In the 2025 Mental Health America rankings, Maryland ranked 40th nationally for youth mental health. That ranking reflects high levels of unmet need and a lack of access to care for children and adolescents, reinforcing the urgency of strengthening early community-based behavioral health services in the state. If Maryland continues to delay implementation of models designed to fix access, crisis response, and continuity, those rankings will not improve. They will only get worse. Delay does not hold the system steady. It reinforces reliance on the most expensive, most strained parts of our system: emergency departments, inpatient beds, and prolonged hospital stays. Previous MDH implementation costs were significantly higher than what we have seen in other CCBHC states. Based on conversations with national experts, those figures seem to rely on assumptions that don't reflect how CCBHCs are actually implemented, including how services are defined and how costs are shared between the state and federal government. Again, under the demonstration, Maryland would receive a 65% federal match, meaning the federal government covers the majority of costs. That enhanced FMAP is intended to lower the state share of the model when it is structured correctly. It is also important that cost discussions reflect the full scope of CCBHC services. CCBHCs are comprehensive community providers, not just outpatient mental health clinics. So limiting assumptions to a single service type doesn't accurately capture how the model functions or how the system costs shift. So as we look at costs, it's important to ensure that the assumptions behind the numbers match this model. And that's not to say that questions about cost are not legitimate. These are significant investments, and your scrutiny is appropriate, including the scrutiny around cost associated with providing services regardless of one's ability to pay. But behavioral health care is already being paid for in Maryland, including for those without insurance, and much of it is being paid for outside of the community. We pay for it through emergency departments. We pay for it through inpatient hospital beds. We pay for it through prolonged hospital stays and repeated cycles of crisis care. The CCBHC model does not eliminate costs. It shifts costs earlier, stabilizes people sooner, and prevents the most expensive outcomes from being the default. And that structure is what allows clinics to sustain same-day access, crisis capacity, and workforce stability. So what is being asked for is not immediate statewide expansion. What is needed now is a clear commitment to moving forward with the demonstration. $6 million in bridge funding to preserve existing CCBHC capacity, and continued legislative oversight to ensure that momentum is not lost. And so I will close where I began. The General Assembly has consistently supported CCBHCs because the model addresses the very problems you can continue to confront: hospital overstays, gaps in behavioral health service access, emergency department overutilization, and fragmented transitions out of inpatient cares. CCBHC models in Maryland are not theoretical. They are operating today. They are producing outcomes that align with national evidence. So again, the question before us is not whether the model works. The question is whether Maryland protects the progress and investment it has already made or continues to fall further behind other states. Thank you.
Thank you for your presentation. So we're not the Budget and Tax Committee.
No, I know.
No, so I mean, a lot of people think we decide where to spend the money. We obviously
Decide on what to
decide the policy. So the plan, I guess, that was presented earlier today is that they're going to stall approving the models, the demonstration
For
until
3
20
fiscal years.
Until
it sounds
how many
like.
years?
It sounds like from FY '26 to FY '29 before they would consider applying for it.
So what happens to your organizations if we do that?
That's a good question. I know that the SAMHSA has said that there will continue to be expansion grants available for grantees. I know that some of these grantees are on their 3rd and 4th cycles of grants, and grants are expensive and difficult and time-consuming to manage. And I think if I'm being 100% honest, I think our providers are frustrated with the continued delay and really wondering, like, is this ever going to happen? And are we just sort of spinning our wheels and continuing with grant funding? So they could get grant funding. Some of them may choose to just say, you know what, we're done, and not continue to get grant funding. And then
So you're operating with grant money now?
absolutely,
With a promise that the SAMHSA grant's going to continue?
with the hope that they continue.
I hope, okay. Thank you for clarifying that.
Of course.
Senator Lamb, I see you putting your light on.
Chair, thank you, Madam Chair. So it sounds like there's a fundamental disagreement with, the impact of this, because when I look at the slide from their presentation, they says delaying the implementation of the demonstration for these years will not disrupt the provision of behavioral health services. So your contention is that there would be significant impacts to behavioral health services.
Yeah, and I think for a couple of reasons. Number one, they've used the grant funding to supplement some of the Medicaid services. So increasing staffing capacities. So making sure that they have staff available for evening and weekend coverage. Using the grant money to offset those salaries. You heard that our behavioral health rates don't cover what it costs for these services. So if we go back to not having that grant funding, those services are at risk of being cut back. So a lot of enhancements have been made. I know that the nursing services that are provided in residential services are not Medicaid covered. So the medical care that they're getting in their residential programs to help them not have to go to hospitals and emergency rooms, that's not Medicaid reimbursable. They've been able to also allow them to do some PRP, psych rehab services that are Medicaid reimbursable, but the medical part of that is not through Medicaid.
And it's been the intention of the legislature to really try to uplift and support BHCs, as we've seen from past legislation, from funding in the budget. I think we had a budget briefing earlier, was that yesterday or earlier this week, that pointed out that the state is actually, that in the proposed budget, there's actually a reduction in behavioral health spend that DBM is projecting, that it seems like our DLS budget analysts are uncertain whether that's accurate or not. And so layered on top of this potential delay or retraction in the progress that's being made with CCBHCs, there's also on top of that potentially budget reductions in available funds for behavioral health programs and services out there.
Absolutely.
Right? Okay. Has CCBHCs seen the need increase over the time that you have trend data for?
I mean, I think overall we've seen the need for behavioral health services increase. So, I don't know that it's specific to CCBHCs as much as it's sort of specific to sort of the state of the world, if you will, at the moment is a little stressful. And I think people are responding to that. And I think the behavioral health need is going up as a result of a variety of things. So
Right.
I would say the short answer is yes, we've seen it. And if you have anything you want to.
I would also just say that it's the effectiveness of the care that's received, right? So if we're looking at the care model for CCBHCs, that's really getting us to those outcomes. The care coordination that is added, that is such a vital component to it, is that piece that's allowing us to avoid those ED visits, those higher cost, those higher utilized services. So it is in fact that additional piece that is layered on top of clinic services that is really getting us those outcomes that we're all seeking.
Mm-hmm. And so this amount being spent really could reap a lot of benefits, and that you've seen a lot of benefits from this already. I guess to summarize, what you're contending is that this would be a penny wise, pound foolish in the end, that we would lose a lot of ground that we've been making, even with this loss of funding, that it may cost us more at the end of all this.
I would say, yeah, and I think part of that is also, remember, there's the enhanced federal FMAP match. If 65%, I think the current behavioral health is 50%. So you're looking at another 15 cents on the dollar that the feds are kicking in for that. My math is, I'm a social worker, so not a mathematician, so bear with me on some of this. But I think currently our CCBHCs are getting about $10.5 million in general funds. If you add on top of that the federal match, that's that $10.5 million with 18.5 million federal match, we're looking at almost $30 million with just that $10 million of state investment if we were to move forward into the demonstration and start drawing down that federal match, because we can't do that as expansion grantees. You can only do that, as Deputy Secretary Lord said, when you're a certified clinic. That's when you get that federal definition. That's when you start drawing down that enhanced FMAP.
So the potential, to summarize what you're saying, the potential is that we're potentially losing more money, leaving more money on the table.
The longer, the longer we delay
Yes.
the demonstration, the more
We're going to be
federal
leaving
dollars.
more money on the table because
Absolutely.
we're losing more of a federal match.
Absolutely.
Yeah. Okay. All right. Thank you.
Thank you, Senator. Any other questions? Thank you for your presentation and,
Thank you.
and your pretty amazing work. I
Thank you.
appreciate the presentation. Thank you. So committee, we're going to take about a 5-minute break so Tammy can switch over to our bill hearing. So it's a good time to take a little walk, but be back in 5 minutes.